on behalf of the organizing committee of the Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe to this webinar. This webinar entitled An Update on Mpox Disease and is conducted in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vitabiotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. Well, as you know, today's topic is on Mpox. We have eminent speaker, Dr. Zainab Malik, Senior Consultant, Pediatrician and Pediatric Infectious Disease at Genesis Healthcare Center, Dubai. And we have eminent panelist, Dr. Fatma Al-Ulama, Senior Consultant, Pediatrician and Head of the Child Health Section of the Dubai Health Authority, DHA. In a short while, I'll be introducing them more. We have moderators well known to you, Dr. Kalpana Sengupta and Dr. Diari Muhammad. Well, as usual, we are having questions. There are the two eminent scientists in this field. Since we are discussing about the viral infection today, just tell us who are these scientists. Those who answer correct, we will announce their name and a token of appreciation will be considered. Well, Dubai, one of the best cities in the world that wants to be number one in all aspects of the life. Well, in an interview by Steve Koff from the CBS News, asking question to His Highness Sheikh Mohammed bin Rashid Al Maktoum, the ruler of Dubai, that what you are planning for Dubai, His Highness said,
trying to do here? What do you want this place to be?
I want it to be number one. Not in the region, but in the world.
What do you mean number one in the world?
In everything. High education, health, housing. Just making my people the highest way of living.
Dubai.
On behalf of all members of Dubai Pediatric Club and on behalf of the organizing committee, well known to you, Dr. Joshi, Dr. Kalpana, Dr. Diari, Dr. Amir, Dr. Ayman, Dr. Rafia, Dr. Bandari, Dr. Leila, and Dr. Khalid Rashid, I would like once again to welcome all of you to this webinar. As I said, our speaker is Dr. Zainab Malik, Senior Consultant, Pediatrician, Pediatric Infectious Disease at Genesis Healthcare Center, Dubai. And our panelist, Dr. Fatima Al-Ulama, Senior Consultant, Pediatrician and Head of the Child Health Section of the Dubai Health Authority. Our moderators, Dr. Kalpana Sengupta, Senior Consultant, Pediatrician and Head of the Department at NMC Specialty Hospital, Dubai, and Secretary of the Dubai Pediatric Club, and Dr. Diari Muhammad, Senior Consultant, Pediatric Surgeon at Al Jalila Children's Hospital, Dubai, and he is the Chairman of the Academic Affairs of the club. Well, I think, yeah. About our future events, I would like to bring your attention on 15th of this month, 15 September, we will have a very important webinar on poisoning in children. Our speaker is Dr. Mahesh Mohitre, Senior Consultant, Pediatrician and Pediatric Intensivist from Mumbai, India. Our panelist is Dr. Deepika Gandhi, Senior Pediatric Intensivist at NMC Royal Hospital, Sharjah. Don't miss 15 September, please. And on 29th of this month, we will have a in-person meeting, antibiotics of choice in respiratory tract infection. Our speaker will be Dr. Joshi. Don't miss that. Well, our 10th annual Dubai Pediatric Club Symposium will be held on Friday, 22nd November 2024. Please save the date. And our sponsor, Dr. Tawfiq Ali, the country business manager of Vitabiotics, who is always helping us. Well, very briefly, I would like to mention about the history of Mpox disease, as you see here, Edward Jenner inoculating the 8 years old child, James Phillips. It was the beginning of smallpox vaccination. The sample was taken from the lesion on the hand of a milkmaid called Sarah Nelms. Very important milestone. Well, I always start in the memory of Hippocrates, the father of medicine, and Edward Jenner, known as the father of vaccinology. Well, the people in the question, the scientists, two scientists, Dr. Martinus Bejernik. He was a Dutch microbiologist who was one of the founders of virology. Since we are talking about the viruses today, Mpox virus, better to remember them. An environmental microbiologist. He is credited with co-discovery of viruses in 1898, which he called it Contagium Vivum Fluidum. And the other one is Dmitry Ivanovsky, a Russian botanist, the co-discoverer of the virus in 1892, and one of the founders of the virology. Remember them. Well, about the Mpox virus, the disease is caused by orthopox virus, monkeypox, formerly called monkeypox virus because it was detected in the monkeys first, a zoonotic virus in the genus orthopox virus. The variola virus, which causes smallpox, is also in this genus. That is why smallpox vaccine acts on this. Well, about the brief history, Mpox was first identified as a distinct illness in 1958 among laboratory monkeys in Copenhagen, Denmark. That is why it is called monkeypox. The first documented human cases occurred in 1970, involving 6 unvaccinated children during the smallpox eradication effort, with the first being a 9-month-old boy in the Democratic Republic of Congo, formerly called Zaire. The virus has been detected in Gambian poached rats, dormice, and African squirrels, which are often used as food. Originally thought to be uncommon in humans, cases have increased since 1980s, possibly as a result of waning immunity following the cessation of the routine smallpox vaccination. Well, my colleague, Dr. Zainab, will talk about this thing. I'm not going to detail of that, how the lesion look like. But about the nomenclature of this disease, the name monkeypox, as I said, originally coined because the disease was first identified in laboratory monkeys. This name was later on criticized as a misnomer, since monkeys are not the main host or reservoir. It was also criticized because the name reinforced racism and stigma about the African country as the source of the disease. Please note, in November 2022, the WHO announced that it will adopt the term Mpox in its communications. So from 2022, the name changed to Mpox. Well, there are different types. The subtypes of monkeyvirus are renamed in August 2022 by WHO. The type of clade, formerly known as Congo Basin, Central Africa, was renamed as clade 1, and the clade formerly known as West Africa was renamed as clade 2. So now they are called clade 1 and clade 2. A global outbreak of clade 2 in 22-23 marked the first incidence of widespread community transmission outside Africa. In July 2022, the WHO declared the outbreak as a public health emergency of international concern, or in the short form, PIG. The WHO reported this status in May 2023 as the outbreak came under the control, citing a combination of vaccination and public health information as successful control measures. Well, but an outbreak of new variants of clade 1 Mpox, known as clade 1b, was detected in Congo during 2023. As of August 2024, just 16 August, it has spread to several African countries, raising concern that it may have adopted to more sustained human transmission. Please note, on 14th August 2024, just few weeks back, the WHO declared this outbreak again as a public health emergency. The following day, Sweden became the first non-African country to report a case. Well, this is the map by WHO on 16th August, just 2-3 weeks back. So showing the reported cases and number of deaths. I'm not going to the detail of that. Well, now about our speaker, as I said, our speaker is Dr. Zainab Malik, very well known to you. Dr. Zainab Malik received a medical degree from Aga Khan University in Pakistan, followed by residency in pediatrics at Duke University Medical Center, North Carolina, United States. She then went on to New York for a fellowship in pediatric infectious diseases at Children's Hospital at Montefiore. Dr. Malik also holds a master's degree in clinical research methods with distinction from Albert Einstein College of Medicine, New York, where her research thesis evaluated host immune responses to human papillomavirus infection in young women. I think she worked with Dr. Kenneth, one of the well-known infectious disease specialists in the United States who works in HPV. She worked for many years as a consultant pediatric infectious disease at Mediclinic City Hospital in Dubai Healthcare City, and currently she works as consultant in general pediatric and pediatric infectious diseases at Genesis Healthcare Center, Dubai. And we have our eminent panelist, Dr. Fatima Olama. Dr. Fatima is senior consultant pediatrician and head of the Child Health section of Dubai Health Authority, DHA. She is director of Dubai Lactation Training Program. She is the leader of early screening program in Dubai. She presented a webinar in this topic. And she is also associate professor at Dubai University. She was very kind enough to give us very brief introduction. Well, my references. So don't forget, Be Wise and Immunized, beautiful painting by Norman Rockwell. Before the shot, this child is very clever. Watching that this doctor is GP, specialist consultant, how many CME he has got. Well, thank you very much. Now I end here. I would like to request Dr. Zainab to start the talk, and I would like to request all viewers to write their question and Q&A box after completion of the talks. We will start the panel discussion. Over to Dr. Zainab, please.
Thank you, Dr. Saurabh, for this wonderful introduction and also for this great introduction to Mpox disease. And I really would like to thank Dr. Saurabh and all the main members of the Dubai Pediatric Club for making sure that we're constantly all kept abreast of any new developments. And of course, Mr. Tawfiq for all of his efforts. So I'm going to be speaking about a really important and pertinent topic that we've all had questions about, so Mpox disease. And so I'm going to cover some of the things that you see here. I'm going to discuss the current status of Mpox infection globally. I think one of the questions that we're all thinking in our minds, I know that our patients are, does this virus have pandemic potential? And I'm going to briefly review the clinical features and disease pathology, I'll talk about another big question that parents and families have about Mpox disease in animals. Very briefly, I'll just give you some references about the Dubai Health Authority guidelines, and I'll leave that to Dr. Fatima. And I'll end with some FAQs that I felt that as clinicians, you might come across in your practice. So just to address some of those questions that you might have. So what is the current status? As Dr. Sarab mentioned, only a few weeks ago, the WHO Director General declared Mpox outbreak a public health emergency of international concern. Now, why was that declaration made? This was made because there was a new clade of Mpox isolated. This is called clade 1b. And there was noticed to be a surge in cases in Democratic Republic of Congo, as well as neighboring African countries. And what's important to remember is that this surge was primarily through sexual contact. Now, what does a WHO public health emergency declaration mean? What does WHO achieve by doing this? Is it just to raise mass panic, or does it actually achieve something? So when WHO announces a public health emergency of concern, it starts the process for a lot of things to happen in the background. It allows the WHO to initiate a coordinated international effort towards collaboration through limiting Mpox outbreaks. And if you remember from Dr. Sarab's slide, in 2022, when Mpox first came on the global horizon, and WHO initiated the public health emergency declaration, international collaboration did get it under control. So unfortunately, after collaboration kind of fell apart, this is a virus that has become a problem again. So hopefully this declaration will mean that everybody starts working together. And this also triggers the process of emergency use listing for Mpox vaccines, which will accelerate vaccine access for lower income countries. It enables organizations like Gavi and UNICEF to procure Mpox vaccine for distribution to low-income populations, which unfortunately bear the brunt of this disease. And it also allows the WHO to release funds from the contingency fund for emergencies. So declaring it a public health emergency is just the tip of the iceberg, and there's a lot of work that starts once this declaration is made. Now, the big question that's in our minds, our families, our patients is, are we going to see a pandemic? Is this a virus that has pandemic potential? And the brief answer is no, it's highly unlikely. And the reason for it is the Mpox transmission dynamics. So this is a virus which is spread primarily through close physical contact, whether this close physical contact occurs with infected individuals, their body fluids, contaminated materials, or respiratory droplets during prolonged face-to-face contact. So you really do need a fair bit of exposure to develop Mpox infection. And unlike respiratory viruses, most recently COVID-19, which do spread easily through aerosols, Mpox transmission dynamics require more direct contact. And hopefully that what this means is that it's not going to spread as efficiently as other airborne infections and airborne viruses. So we should really not see a pandemic. And obviously, what we still do need to do is collaborate at an international level and try and limit the disease progression. So to give you an idea about where Mpox stands compared to other viruses, there is a number called R0. And in a very simple way, this is a number that tells you about how contagious a virus is. So Mpox has an R0 value of between 0.57 to 1.25, which means that somebody who is infected with Mpox is probably going to infect one other person. And if you compare that with influenza, people with influenza are probably going to infect up to 2 other people. COVID, some of the strains had an R0 of up to 5.7 or 6. So one person with COVID was able to infect about 6 other people. But the most transmissible virus is measles. And because of its very efficient airborne transmission, it can, somebody who has measles infection can infect up to 18 other people. This is the most updated world map from the World Health Organization that looks at cases from 1st of January 2022 to the 30th of June 2024. So this is looking at the entire time horizon from when Mpox was first, when it first came on the global stage. And you can see that there are certain countries where they're seeing more Mpox than others. But I do think that this world map underestimates the global estimate, because there are lots of countries where it's not a disease that's being tested for. There might not be enough resources or awareness. So I would take this with a pinch of salt, but what it does show us is that Mpox cases are pretty much identified in most countries. And again, this is a graph that looks at Mpox distribution between the 1st of January 2024 to the 30th of June. And you can see that certain regions in the world are overrepresented. You don't see a whole lot in the European region despite surveillance. You're seeing a very, very small proportion in Southeast Asia, but I suspect that that's probably more of a screening, more of a reporting bias, because those are, Southeast Asian region is an area where there's crowding, there's a lot of, there's a scarcity of resources. So this is an area where potentially this virus can spread efficiently. And in the multi-country outbreak of Mpox, the most recent external situation report that was published just a few weeks ago, the risk assessment is really high for Democratic Republic of Congo and neighboring countries. And just to bring back to your attention that Congo, Mpox has been endemic for a very, very long time. It was first isolated decades ago, and there used to be intermittent cases of infections in humans. So Congo is an endemic area for Mpox. In other countries like Nigeria, West Central and East Africa, where it's also endemic, the risk is not as high as in Congo, the risk is moderate. And around the world, and the rest of the countries in Asia and around the world, the risk is moderate. Now, I really want you to focus that this is a virus that is spread primarily through sexual contact, and not just a hetero sexual contact, but also primarily through men who have sex with men. So it is not an easy virus to spread. So moving on to the clinical features. Like any other viral infection, it starts off with a prodromal phase with fever, lymphadenopathy, malaise, headache, or sore throat. The reason why I've put lymphadenopathy in bold is because this could be a clinically differentiating feature. Most other viral illnesses do not give you lymphadenopathy, especially in the prodromal phase, because the viral load or the viremia is not that high. But this is an infection that you can see lymphadenopathy even in the prodromal phase before somebody actually starts to develop the rash. And the rash progresses through multiple stages, and I'm going to illustrate that in a later slide. It starts off as macules that progress to papules, and then firm vesicles, and eventually to deep pustules. And it's important to know the various stages of rash because they might be confused with several other diseases. The rash of Mpox starts on the face. This is very different from rashes in chickenpox, for example, that starts more centrally on the trunk. Hand, foot, and mouth usually starts on the hand or feet. And this is a viral rash that has a centrifugal distribution, which means that the palms and soles and extremities are affected more than the trunk. And contrast this with chickenpox, which has a centripetal distribution, which means that it's a lot more central than in the peripheries. And lesions are in the same stage of evolution in the same area. When, we've got a lot of kids coming in with hand, foot, and mouth. And when you look at them, their hands, for example, you will have some macules, you'll have some early papules, you'll have some vesicles. But in Mpox, in the same area of the body, the lesions are likely to be in the same stage. And this can be also a very important distinguishing factor from chickenpox. In chickenpox, the lesions are at different stages of evolution. Sometimes the pustules can be umbilicated, which means they have a little dot in the middle, confusing them with molluscum. And these are painful until healed. So these are not just vesicles that are there, they're deep, painful pustules until somebody has completely recovered from Mpox infection. So in that way, a lot of the rash characteristics, the disease progression, they are very, very similar to smallpox, which is why those vaccines are being used during the Mpox outbreak. And this slide further illustrates the stages, and these are available on the CDC website. So as you can see, the first stage starts out as a macule, which is basically just an erythematous flat surface on the skin. These are just red spots. You don't actually feel anything on the skin surface. And this generally lasts for about 1 to 2 days before it recovers on its own. Then comes stage 2, which is a papule, where these red dots start to look a little bit raised. They're hard, raised bumps. This also lasts for about 1 to 2 days. And then stage 3 is a vesicle. It's a traditional vesicle. They get larger, they look like blisters, and initially they're filled with clear fluid. So in the first 3 stages, you could confuse that with chickenpox or with hand, foot, and mouth, but it is really important to look for lymphadenopathy, look at the age of the patient, look at where the lesions are concentrated. Now, stage 4 and 5 are very specific to this category of viruses, which includes cowpox and Mpox, as well as smallpox. Stage 4 is the pustules. These lesions start to they're not filled with any clear fluid anymore. They're actually filled with pus, and these are lesions that are deep. You're not going to be able to unroof them easily. And this is a pus-filled blister, and this stage lasts for 5 to 7 days. And these blisters and pustules are quite painful. And stage 5 is the scabbing stage. Like most other viral exanthems, the spots crust over and become scabs that eventually fall off. And people are considered contagious all the way from the prodromal phase, all the way till the scabs come off. And not just until the scabs come off, but until a new fresh layer of skin has formed underneath the scabs. And these are what some of the pictures of this rash can look like on various skin tones. As you can see, the first picture up here, it looks like a pretty firm papule or a pretty firm vesicle. It's hard to know what the contents look like, but definitely it's not your run-of-the-mill vesicle. This is a really, really firm papule. This is a lesion with a central umbilication. And of course, when you have somebody with molluscum, they're not going to have usually, unless molluscum has secondarily been infected with staph or strep, you typically don't get systemic features, you don't get the regional lymphadenopathy, and obviously with Mpox, you would expect not just one lesion, but multiple lesions. This is a rash that is starting to scab over. These are multiple scabby lesions. They can be very confused with necrotic skin lesions if you don't have the full history. And this is, you can see that the scab is starting to come off. And here are some other pictures. You can see that these are really deep, deep pustules. And you can see here, this vesicle is filled with pus and it's painful. There is erythema, a little bit of induration around it, and similar lesions here. These are lesions at other phases of development. So this is a rash. It's worthwhile. There are lots of online atlases. It's worthwhile to familiarize yourself with what this rash could look like at various stages and in different skin tones. So what is the differential diagnosis of Mpox in pediatrics? It's likely to be confused with varicella infection. Of course, it's important to take the history. It's important to look at the symptoms, exposure. Most of our population is highly vaccinated with the varicella vaccine. And again, look at the lesion distribution. Varicella is more central. Mpox is a much more peripheral rash distribution. And with varicella, you get lesions at various stages of development, versus with Mpox, in one area, they should all be in the same phase. Hand, foot, and mouth infection, we're seeing a lot of it these days. These are much younger kids. And again, very characteristic vesicular rash that starts out in the hands. And they don't usually, obviously, are not going to progress to those pustules, and they're not going to have as significant the clinical systemic features. They're not going to have the regional lymphadenopathy. Molluscum contagiosum would be a differential if there are 1 or 2 lesions, but when you've got significant lesions that you get with Mpox, you should be able to rule that off your list. Some of the other differentials that are listed, with WHO and CDC are scabies, drug eruptions, insect bites, and allergic reactions. But with those, it should be very easy to get to rule them out of your list. With scabies, for example, intense pruritus would be an important differentiating factor versus the painful rash of Mpox. And this is a great picture. Smallpox, Mpox, this is the disease distribution, primarily face, hands, legs. And you can see that centrally, there's less rash in the center. So it's a centrifugal rash distribution versus chickenpox. A lot of the rashes occur centrally. So you get much fewer lesions on the extremities. So just one of the things to keep in mind. And this is where getting a really good history where the rash started would be important. What do you do with somebody who has a rash? The American Academy of Dermatology just suggests regular care, moisturizing, making sure those people are showering and looking for signs of secondary infection. So another question to consider is, what about animal exposure? A lot of households in the UAE and Dubai have pets. What is the risk to family members or to children? So this is a disease, as Dr. Saurabh mentioned, that monkeys are not the only source. So rodents can harbor Mpox virus, and prairie dogs, squirrels. So if there is somebody who's got a hamster at home or a guinea pig, those are also rodents. They can be infected with Mpox. And this is where, just generally speaking, at any time, if the animal is looking different or behaving differently, they should be seen by their vet. But rodents, including hamsters and guinea pigs, can potentially be infected. Domestic pets like dogs and cats, it is unknown whether or not they can be infected with Mpox, but it is well known that they can be infected with other orthopox viruses. And orthopox is the main family of viruses to which Mpox belongs. So one would think that if they can be infected with other orthopox viruses, it is potentially possible that they might get infected with Mpox as well. But with domestic rabbits, the adult ones especially, it is established that yes, they can be infected. So as a general rule, if there's an animal that is not behaving well, they should be seen by their vet to make sure that they're healthy. An important thing to keep in mind is we live in an area where camel farms are there, and there might be camel exposures. It is not known whether the camels can be infected with Mpox, but yes, they can be infected with other orthopox viruses. So what are the guidelines? So the Dubai Health Authority has been fantastic. They've been really, really proactive with keeping healthcare professionals up to date. And very recently, they released a circular to enhance surveillance of monkeypox. And I would like to bring your attention to these guidelines for the management of monkeypox infection that were released back in 2022, when monkeypox or Mpox first emerged on the global horizon. And these are fantastic guidelines. They're evidence-based. A lot of work has gone into developing these guidelines. And they go from giving you a background on the virus to the case definition, surveillance, clinical features, when to collect a sample, how to collect it, and all the processes that go into contacting DHA, who to call, and get samples delivered. So I would urge all of you to download these guidelines. These are available for free online. and use this as an important resource. I'm not going to discuss any of these any further. I'll leave that to the expert, Dr. Fatma, to review the DHA updates. So moving on to some FAQs, because obviously I don't want to burden you with a lot of information, but at the same time, I do think that clinically a lot of questions pop up in our heads. So I just wanted to address them through questions. So a very common question that I get asked is, when can a person spread Mpox? So somebody who has confirmed Mpox infection is considered contagious from 1 to 4 days before onset of rash, until the rash is fully healed and a fresh layer of skin has formed. So, and that can take up to 2 weeks and sometimes even 4 weeks. So it is important to know that somebody is considered contagious a couple of days before they start to show symptoms of disease. And how is it spread? So the spread is driven by close or intimate contact. And so there has to be either direct skin-to-skin contact with somebody with an Mpox rash or with the scabs, because even the scabs are considered highly contagious. If there's contact with saliva, upper respiratory secretions, or intimate bodily fluids, for example, during sexual contact from a person with Mpox. Pregnant women with Mpox can transmit to their neonate. And contact with formites, like objects, fabrics, surfaces that have not been properly disinfected after use. Now, I'd like to say that there's only been one case of formite transmission through shared towels, and this was reported right in the beginning in 2022. So a shared towel is a pretty intense contact. You know, a towel's been on somebody's skin, potentially contaminated with a lot of that person's secretions, but it doesn't seem to be transmitted by if somebody's touched a doorknob or an elevator button, or so casual contact through formites does not seem to spread it, which again is good news for us, because this means that the potential for spread of this virus is not extremely high. Another question, especially in this season where people want to attend community pools, they want to go to water parks, can Mpox be spread through water in swimming pools, hot tubs, splash pads, or even recreational water parks? So the CDC says that there have been no clear link of Mpox transmission through these water-based resources, because chlorine seems to kill the Mpox virus. And as long as the pools and the water parks are chlorinated to the international standards, there is no transmission risk. So kids can go and attend their classes, their swimming classes at school. They can continue their swimming lessons. We don't need to panic. And the Dubai municipality is extremely strict with commercial water venues to make sure that they're chlorinated to an adequate level. So definitely in Dubai, we should not have a problem with transmission through swimming pools and water parks. What is the incubation period for Mpox? It's usually between 3 to 17 days. So an average of 2 weeks, you would say. So if somebody's been exposed to a person with confirmed Mpox, you almost have to give them an observation time of 2 weeks to see if they start to have fever, any prodromal symptoms with lymphadenopathy, or start to develop any rash. And if after 2 weeks they don't have any symptoms, it's unlikely that they were actually infected after that exposure. So what should you do if somebody's exposed to Mpox? If your patient calls you and says, you know, I've been exposed, I think it's important, just like with any early pandemic or any outbreak, when we don't really know a lot about the disease, to make sure that you're involving the health authority. There's a listed number where you can call them, you can send them an email, but report it to DHA. And remember that in the vast majority of people, this is a self-limited disease. So you really have to curb the panic. And there is a role of post-exposure prophylaxis with vaccination. Again, how widely available is vaccination? Not everybody is a candidate, so that's something for you to know from an academic perspective. But in the vast majority of patients, you're going to report them to DHA. You're going to ask them that, look, the incubation period is 14 days. If you develop any symptoms, these are the symptoms to look out for, but don't panic. This is going to be a self-limited disease in the vast number of people. So what should you do in a hospital setting? Let's say there's a pregnant woman who comes in, and during delivery, there are lesions that are concerning for Mpox, or she has a confirmed Mpox infection. So what should you do for the neonate? So the most updated guidelines from the American Academy of Pediatrics suggest that infants should be physically removed from mom, because obviously intimate contact with somebody who's got active lesions is a concern for transmission. So the neonate or infant should be placed in a separate room, and direct contact with the parent or infected caregivers should be minimized. You should try and bathe the neonate early. So again, what you're trying to do is decolonize, decontaminate the skin. And in the United States, one can offer post-exposure prophylaxis for the infant for anti-variola immunoglobulin. Anti-variola immunoglobulin was an anti-smallpox immunoglobulin that was developed after smallpox vaccinations. Do some people react to smallpox vaccine? So this was an antibody that was developed specifically against smallpox. So the Red Book recommends that this could be considered for the neonate. For now, breastfeeding needs to be avoided because we don't know how much transmission occurs through breast milk. If a mom has confirmed Mpox, if she's viremic, which she has a high viral load of Mpox virus in her blood, she could be shedding it into her breast milk. So for now, breastfeeding needs to be avoided. And the neonate should be monitored for signs of Mpox for up to 21 days post-exposure. In a hospital setting, this would mean looking out for fever, lymphadenopathy, looking for a rash with daily temperature checks and a full skin examination. So what are the precautions that are advised for patients who are hospitalized with suspected Mpox? Let's say if you have somebody who's immunocompromised, they've got these funny skin lesions, and you have to hospitalize them. So what do? So the CDC recommends that you admit them into a single room, no shared rooms for these patients. Good hand hygiene. This is very old-fashioned, but it's one of those old-fashioned things that's always in style. So you can't go wrong with really washing your hands well. So good hand hygiene takes priority. So as a healthcare provider, if you're going to go into the room, have contact with the patient, talk to them, examine them, the CDC right now is recommending an N95 mask, even though it's not a traditionally aerosolized virus. But if you're going to have close contact, you're going to examine their mouth, you might talk to them. There is concern about droplets as well. So for now, they're recommending an N95 mask, gown, gloves, and eye protection, of course, because that makes sense. And these recommendations might change. They might change that to a regular mask, but for now, N95 mask is recommended. And if you're considering that this is a patient who's going to need a bedside bronchoscopy or suctioning, if there's a procedure that generates aerosols, then move the patient to a negative pressure room and take all the negative pressure precautions. And there needs to be adequate disposal and cleaning of bedding and other material that are likely to be contaminated with the patient's secretions. So what are the vaccines? I'll touch upon the vaccines. There are two vaccines that are available for prevention of Mpox. One is a Janos, which is a live but non-replicating vaccinia virus vaccine. So vaccinia virus is a smallpox virus. This was a vaccine that was developed against smallpox, but in contrast to other live vaccines, this does not replicate. And it has been licensed by the FDA since 2019 for prevention of Mpox and smallpox. And people need 2 doses separated by 28 days. For now, it has an emergency use authorization for people over 18 years of age who are at risk of Mpox. And these risk factors include sexual risk factors. So not everybody who's immunocompromised is going to be a candidate for this. These are going to be very, very selected few people over the age of 18. And this vaccine can be used for post-exposure prophylaxis, ideally within 4 days post-exposure. And because it's a live vaccine, it can still be effective if given up to 2 weeks after exposure. ACAM 2000, this is a live replicating vaccinia virus vaccine. And this was primarily developed for smallpox prevention, but FDA has given it an emergency authorization for smallpox prevention. It's a single dose, but because it is a replicating vaccine, there is a potential for shedding of the virus in the person who's received the vaccine. So if there are household contacts who are immunocompromised or somebody who has severe eczema, this can lead to problems like eczema vaccinatum. So how do you diagnose Mpox? A lot of these details are given in the DHA policy. So these viruses can be detected in the swab of a lesion, in the lesion crust, or even the exudate by nucleic acid amplification tests that are specific for orthopox viruses. As clinicians, we always want to unroof vesicles and aspirate lesions. For this virus, unroofing or aspirating is not recommended. The CDC says, do not do this. There's enough virus outside the lesion, around the lesion. You don't want to unroof or aspirate it because the risk of then transmitting it to healthcare personnel and others increases. And you can contact DHA for guidance on how to collect a sample, how to transport it, and all of those details are given really well in the guidelines. So what needs to be done if somebody develops Mpox infection? Obviously, if you're concerned, you're seeing a patient, you're concerned that they might have Mpox, call DHA, report it to them. And remember, don't panic. Most patients with Mpox will have self-limited disease. And it's really important to make sure that you counsel patients to not touch their eyes, because if there's ocular or periorbital Mpox lesions, they can quickly progress to keratitis and lead to permanent visual disability. And these patients will then need urgent ophthalmology review and treatment with topical trifluridine therapy to minimize visual loss. So if you've got skin lesions, make sure you're not touching your eyes. That's the message to patients. And these patients should be placed in isolation, and they should be isolated until all scabs have fallen off and a fresh layer of skin has formed. And this can take up from 2 to 4 weeks. So these patients should not come out of isolation until they've got a brand new fresh layer of skin. That's when you can make sure that they're not contagious to anybody. So what are some of the treatment options? Like I said, the vast majority of people will have self-limited disease, so you don't need to do anything. There are antiviral agents available, which can be used in immunocompromised patients or those who have severe systemic disease. And vaccinia virus immunoglobulin, which was originally licensed for complications of smallpox vaccination, has been approved by FDA for post-exposure prophylaxis, also for neonates. However, there's no published efficacy data in preventing Mpox disease. So what we're doing is they gave an emergency use authorization for vaccinia immunoglobulin just because from a molecular structure point of view, Mpox virus is very similar to smallpox virus. So this is the same reason why we're using the smallpox vaccine to protect against sorry, just give me. Sorry about that. My dog needed to leave the room. So one of the things that I would really urge you to do is keep calm and use your common sense. And it is really important for us as clinicians to make sure that we have all the information and we're giving patients the facts, and they're not just getting all their information from from other sources that are not evidence-based. So there's a lot of hype, there's a lot of panic around Mpox, but remember, this is primarily a virus that is transmitted through sexual routes. So the physicians who deal with adults, they're probably going to see it a lot more than we are in pediatrics. And in the adult world, if there is somebody who comes in where they're concerned that this patient might have Mpox, those patients should be screened for other sexually transmitted diseases, hepatitis C, HIV, and all of that. Luckily, in the pediatric world here in the UAE, we don't have those kinds of issues. So let's keep calm and use our common sense. And with that, I would like to thank you for your attention.
Thank you very much, Dr. Zainab, for this excellent illustrative presentation. Now I'd like to request Dr. Fatima if she's ready to tell us about the DHA guidelines, the latest guidelines on this Mpox, because many viewers and members they had asked about the latest guidelines. Dr. Fatima, please.
Good evening, Dr. Sahrab.
Good evening. Yes, please.
Dr. Zainab and all audience. And Dr. Zainab made my life easy, so she spoke about everything. Now I don't know why my slide is not moving. So I wanted to go only to the area which related to just I want to tell if you whenever you see the monkeypox, you will know it from the rash which you have never seen in your life. The rash is really specific. So I will ask Dr. Sahrab asked me, I will go to talk about the guidelines and related to monkeypox, which was published in from Dubai Health Authority. Okay. Okay, it's in May 22, there are some cases reported of monkeypox in UAE. And guidelines for management of monkeypox viral infection, it is saying that what to do if you have any cases of monkeypox in any area in Dubai, private or even in government or any area. In general, they have to refer the cases if they have adult above age of 18 years to our Rashid hospitals. Children below age 18 years, it should be referred to Al Jalila Children Hospitals. And if you have come across of any pregnant ladies with monkeypox, you should direct them to Latifa Hospital. So if they received a sample from non-DHA labs, it is actually free for all samples. So they no need to take money from any of your clients. You can send the sample directly to Rashid Hospital lab, and it will be free of charge. And their lab is working 24 hours in a day, and their extension is mentioned in their website. Regarding what is the DHA, Dubai Health Authority protocol regarding monkeypox, that preventive medicine section, they've advised all private health facilities to electronically notify suspected and confirmed case of monkeypox directly through the infectious disease notification in the web portal, and all electronic notifications should be followed by immediately calling the preventive medicine section hotline. So they did really a great job. There is a hotline. They can call them any times in a day or night. And there are some people to answer their question and to direct them what to do. Regarding vaccine, already Dr. Zainab, she mentioned, but according to the report in GCC country, only the Bahrain elected to offer the vaccine for people interested in taking it as a 2-dose of June during 2022 outbreak. And also now it is available with them, as they mentioned, but in UAE, we don't have any vaccine till now. Current CDC recommendation as well as GCDC are directed mainly towards the healthcare provider and biology lab staff because they are telling we don't have enough the vaccine to give to all the people. So I will not talk about vaccine because Dr. Zainab already mentioned how many doses and what is the interval and everything. So only my part was to take and talk about the guidelines, and thank you so much for all audience and our organizer
Thank
committee.
you very
Thank you.
much. Thank you very much, Dr. Fatima, for this informative talk and updating us about the DHA guidelines. Now, I would like to request our moderators, Dr. Kalpana Sengupta, Senior Specialist, Senior Consultant Pediatrician and Head of Department at NMC, Secretary of the Club, and Dr. Diari, Senior Consultant Pediatric Surgeon at Jalila Children's Hospital, the chairman of the academic affairs, to join and start the Q&A. There are a lot of questions, and I'd like to request Dr. Zainab and Dr. Fatima also to join the panel. So, Dr. Kalpana, please. Sorry, I have some problem with my videos. I don't know. People are fed up of seeing my face. I think they have deleted my videos. Please.
Thank you, Dr. Sora. So, thank you, Dr. Zainab and Dr. Fatma, for interesting talks. As it is a topic that is currently, in news, and people want to ask questions about it, starting with the incidence of Mpox in pediatrics. As
Cannot hear
primarily,
you, Doctor.
Hello. Hello, can you hear me?
Yes.
Yes, please.
Okay. Okay. So what is the incidence of Mpox in pediatric age group? And what is the primary source? As you showed, mainly it is spread through sexual contact. So Dr. Zainab.
So it is primarily spread through sexual contact, but obviously close contact with somebody who's highly infected can occur. So if you imagine, let's say there's an adult who might have lesions, sexually transmitted lesions, and then they might get a few rashes on their hands, and they're in contact with their children. That is obviously one of the sources, and which is why the concern is that this is going to spread in countries where there's a lot of crowding, there's lack of access to healthcare and clean drinking water. So, which is why this is likely going to be a disease of, unfortunately, the lower income countries. So pediatric transmission will potentially occur from a close adult who potentially has sexually acquired lesions or got infected in some way, and then has transferred it to the child.
Right. So going further, Dr. Barai Dardari wants to know, is the current strain more contagious and causing higher risk of infection in pediatrics?
So there has been a change in the clade that's causing more of the outbreaks more recently, and that was one of the reasons that the WHO raised this as a public health emergency. It seems that the newer clade is more efficient at causing human-to-human transmission than the previous clade, not specifically in pediatrics, but generally speaking, it is still primarily a sexually transmissible disease or with close personal contact. But yes, one of the reasons for concern was that the newly identified clade seems to transmit much more efficiently than the older one.
Yeah, in fact, if I'm not wrong, the RO mentioned by you, it's in general, but this current infection, they said it was 1.1 to 2.4. So probably a bit higher than what was mentioned earlier. Yeah. Dr. Diari.
Yeah. Thank you, Dr. Zainab and Dr. Fatma, for this nice presentation. Now, there is another question about the characteristic feature of the lymphadenopathy associated with Mpox. If there is any, you mentioned that there is a lymphadenopathy in this viral infection, which is unusual. So is there any characteristic feature? I think Dr. Fatma also in the guidelines, there is some lymphadenopathy explanation. So if both of you can answer this question.
So just generally with viral illnesses, you would tend to see lymphadenopathy after the rashes have started. So usually with either hand, foot, and mouth or chickenpox once the rash has begun. So the reason why lymphadenopathy for Mpox is described in all the guidelines is that this tends to occur in the prodromal phase. And the possible mechanism that I can think of is that there is a significantly high viremia, and there's a significant immunological response, and which is why people are considered contagious even in the prodromal phase of the disease. So there are no specific, I haven't read, obviously I've never seen a patient with Mpox, but I haven't read anywhere whether this is painful lymphadenopathy or painless, but it's just described. And this can be an important distinguishing factor that if you do see somebody with non-specific symptoms and you feel lymph nodes, we always tend to jump into TB, for example. But obviously nowadays, maybe think about, could they be in the prodromal phase? Do you need to tell them, keep an eye out, make sure you're not touching your eyes, contact DHA, ask about exposure history. But unfortunately, I don't know anything more about the lymphadenopathy.
So if I make
Dr. Diari, in the guidelines, yeah, they mentioned that lymphadenopathy usually occurs in 1 to 3 days after the onset of fever, and it is rarely concurrent with the onset of the rash. And as Dr. Zainab mentioned, and we well known that like other viral disease, mainly it can occur, you can see it in submandibular gland, in the neck, axilla, or groin, and it might appear on both sides or only one side of the body, and sometimes can be painful, the lymphadenopathy in case of monkeypox disease.
So it is a generalized lymphadenopathy, cervical, axillary, groin.
Yes, yes.
Okay. So there was another question. Most difficult part of the diagnosis is that between the chickenpox and Mpox. So initially when the rash is minimal, how do we can differentiate between these two?
So again, look at the distribution of rashes. Chickenpox, primarily in unvaccinated people, will start centrally. They will end up with a lesion on the neck, the abdomen, around the mouth, versus with Mpox, the lesions start peripherally. Another important distinguishing factor is with chickenpox, you see lesions in various stages. So you'll see vesicles, you'll see kind of initial papules and macules, versus in Mpox, it seems that, let's say, if you're looking at the hands, all the lesions generally tend to be in the same phase of development. And once the rash has progressed, it becomes much more of a deep pustule. That's when it becomes painful, which is unusual for chickenpox or varicella infection, where it's a lot more itchy unless it's got secondarily infected. But I would say, look at the exposure history. We have very, very high vaccination rates with varicella vaccine at 1 year and 4 years of age. We don't usually see a lot of natural chickenpox infection. So if somebody is being fully vaccinated against chickenpox and they're presenting with lesions that are more concentrated on the face, hands, then it would certainly be worthwhile thinking about Mpox. But having said that, it's not very common in pediatrics.
I think there are a couple of questions related to smallpox vaccination and whether it is protective against Mpox. So any comment on that?
I think we're just theoretically saying that Mpox, that vaccination with smallpox is likely to protect against Mpox disease. Now, people who've received smallpox vaccination, who were born in the era you would expect that they might still have immunity because smallpox vaccine is a live vaccine. It's actually highly replicating the old school vaccinia virus vaccine. It was quite potent. And so you would expect that there should be some element of protection. And, you know, another question that people have is if somebody's had Mpox once, can they get it again? And
Again.
these viruses, orthopox viruses, do elicit a pretty robust immune response. So you would hope that that immunity should protect them against subsequent infections after exposure to Mpox, similar to what vaccination will do for them.
Right. There's a question about availability of vaccine or how to get it in Abu Dhabi. Maybe Dr. Fatima can help us with that.
Till now, actually, we don't have, the vaccine is not available in UAE.
Mhm.
And maybe in the near future we can get it, but now, no, I said among Gulf country, only the Bahrain, they got it. But the rest, no.
Okay. Dr. Priyanka Banerjee wants to know, any screening is being done at the airports from high-risk places? Dr. Zainab, any idea?
I think it'll be very, very tricky. What do you do for screening? You know, do you do a clinical exam on everybody, strip them? You know, so it's highly unlikely. And like I said, there's only been one case of formite-related transmission, and that too in 2022 through shared towels. So this is not a virus that's likely to spread through, you know, sitting on, you know, touching a door or going to the same bathroom that somebody with Mpox had. So transmission dynamics are different. And I think this is where countries also need to be smart. You know, we don't want to have a widespread panic about this disease. This is very, very different from the COVID issue. So there's really no need to screen. There's no need to screen people for this.
Right. Dr. Biari?
Yeah, so is there, Dr. Muhammad is asking, any currently diagnosed case in pediatric age group in UAE? Personally, I don't think there was any case pediatric. Dr. Fatma, you have any idea?
No, not till now. We did not come across of any case of pediatric. I asked even our
Pediatric.
public health. No, till now, no. Inshallah, it will not be there.
Inshallah. Again, the same doctor asking about mortality rate. Although you mentioned a couple of times that it is a self-limiting, but is there any mortality reported?
There have been, and if you look at Dr. Sorab's slide, there have been a few cases of mortality in some of the African countries, but very, very few. And remember that because it is a disease that's transmitted through sexual contact, we don't have any information were those people who died, did they have HIV, for example, which would all automatically mean that their immune system is compromised. But there is a theoretical concern that, for example, somebody who's on immunosuppressive therapy, chemotherapy, high doses of steroids, if they were to get Mpox infection, they might get extremely sick and develop complications. So there are certain antivirals that can be used in that population. So the mortality from the data that I've seen seems to be extremely low, just maybe a handful of deaths, but potentially those people might have had some other risk factors as well.
If
Another
without
question about
possible complication of
yeah.
Mpox, like chickenpox.
Yeah, so
have
there are some people can have extremely fulminant disease. They can go into multi-organ failure, and that's usually the cause of death. So that's another population where antivirals can be used if people are not responding in a self-limited way that you would expect. And you're always, with any disease, you will have a handful of people who react differently to infections, probably based on their genomic structure. But yes, multi-organ complications can occur, but again, very unusual. And if you look at the data from the WHO and CDC, it seems like pretty much anything can happen, from bone marrow failure to liver failure and everything.
Right.
Is it lifelong immunity if you get the infection?
So somebody who has a poor immune system obviously will not be able to generate an adequate immune response to contain it. So they're much more likely to develop the complications from it.
No, immunity. If it will be an immune all the life if it is get infection, that there is a recurrence of infection, reinfection?
So one
Or
would
it will give
expect
you
that it would, yeah, it would probably, again, this is still a relatively new virus, so we don't know how long somebody is protected. But I would expect that definitely in the short to medium term, it should give you the antibodies that you need to protect subsequent episodes, similar to what smallpox vaccination does, that it does cause protection. And so far, no booster doses are required.
Okay. So, any question from you, Dr. Saurabh? I think we've run through all the audience
Well,
questions.
my video is not working. No, the question is, suppose no, because they were saying those who received the about the smallpox vaccine. I had seen some pictures even in CDC. Those who received the vaccine and those who didn't receive, how severe was this disease on them? Uh, they said that those who received the vaccine, although I mean before 1980s, they're much protected. What is your opinion? Suppose if we go back and give them again the smallpox vaccine. Suppose if we don't have vaccine, only a smallpox vaccine is there. Can we use it in future?
So the currently licensed vaccines that are being used for Mpox were actually developed for variola. They were developed for smallpox. So it is the smallpox vaccine that's being used for Mpox prevention.
Thank you.
I think the rest of questions are, differential diagnosis from various viral diseases which cause very characteristic clinical features. I think question is, how do you differentiate it from hand, foot, mouth? How do you differentiate from fifth disease? So, yeah.
One thing, Dr. Kalman, sorry, I'm interrupting. Dr. Zainab said also, people are asking about chickenpox. I had a professor saying chickenpox is like a rose flower buds. One is a small bud, one is half frozen, one is full, one is just falling off. Exactly like that. As you said, chickenpox never have same lesion as in hand, foot, mouth. This is a, I think, good differentiating point. At different stages, different eruption and the site also, site of the this lesion. This, I mean, clinically we can differentiate. And as Dr. Fatima said also, these are unique, uniform, very characteristic.
Dr. Zainab, about newborns who get infected, is the clinical course similar to, say, older kids?
So
Is it as self-limiting?
I don't know, because there doesn't seem to be a lot of data on newborns. And even I think the recommendations that I shared with you today, and I do think that those are going to change, because remember, even in the beginning of COVID, there were very strict recommendations: don't breastfeed, isolate, different room. And then as we understood the virus a little bit better, those things changed. So I think that we're probably going to see a lot of change, and it is possible that the newborn response also depends on what stage of pregnancy mom was infected. Right now, we have no idea, is this a virus that's teratogenic? At what stage will the newborn be protected versus how viremic is the mom? Does it make its way through the placenta? So I think we still have a lot more information that we need.
Maybe more protected as antibodies maybe will go through the placenta or even from
Exactly.
lactation, maybe through lactation, maybe.
Yeah, Yeah, exactly. So I
Yeah.
think it's still a gray area. There just hasn't been enough evidence, probably.
Right.
Until now, we don't have any like congenital abnormalities like Zika virus. When in Brazil and there, they were saying that it causes some microcephaly and these things we don't have with
Yeah.
this one.
And also, I think if you look at the numbers, the number of cases have not really been high. And I haven't looked at the data, but it does seem to be a disease that's predominant in men, because and not just heterosexual men, but men who have sex with men. So it's a very specific population that's at high risk. So which is again one of the reasons where we do need to. Now everybody's going to go back tomorrow and see any vesicle and think of Mpox, but I think this is where we really have to use our good clinical skills and judgment and make sure that we're not causing unnecessary panic.
Question about Dr. Zainab. They mentioned about this pain with lymphadenopathy. Usually viral infections do not cause a painful lymphadenopathy. The one is rubella, posterior auricular lymph node pain. I mean, when a child comes with rash and you feel posterior auricular lymph node, which is painful, I mean, diagnosis goes with the. This is another one where they have mentioned painful lymphadenopathy, especially when child gets, this lymph node enlargement, they are painful. This is one of the differentiating because only in rubella we get posterior auricular, and this is the other. I mean, chickenpox you don't get, or in the hand, foot, mouth, painful lymphadenopathy. This is a differentiating feature for them because one of the main features, fever, painful lymphadenopathy. I mean, one of the differentiating points.
Absolutely. And even the rash, when it's those deep pustules, those are painful pustules, unlike hand, foot, and mouth or chickenpox, where it's more of an itchy situation. So this is a painful rash.
Okay, I think there's a question from Dr. Afnan Sharif asking that Mpox started in 1958. Why don't we still know much about it?
That's the $1 million question. I think that we unfortunately we live in a world where diseases that don't affect the vast majority of people, or it's not, research is expensive and it's all driven by health economics. So why don't we have vaccines for TB? Because it's not a disease of the developed countries, So in the same vein, I think that a lot of this is driven by health economics, and it's just not in anybody's interest to spend millions of dollars researching a disease that won't get any revenue at the end of it, I think.
May I give a comment on this? This 1958 in Copenhagen, while these monkeys were in the lab, they got infected. That time there was no question of the human. Went on to 1970 during a smallpox vaccination, they found 6 cases in the Congo, that time we called Zaire, and the first one was a 9 month child. After that, there wasn't any, big epidemic for WHO to declare it as warning. Or in 2022 only they declared it as a emergency, public health emergency. On 23 again they said no, this is over, no more emergency. Now on this 14th August 2024, because it is spread to other countries, they have declared. That is why we don't have literature on that, since humans are not that much involved. Now it has created little havoc. Top people started doing research. In future, we will have a lot of information. That is why we don't have much information, because we didn't have much, human involvement in the 1958. That was in the monkey.
Exactly like Ebola also. It was there for years, for decades, and nobody took action about it.
The quotation by Charcot said, disease is very old and nothing about it has been changed. It is we who change as we learn to recognize what was formerly imperceptible. Things were, as the knowledge advances,
Dr.
we
Zora,
come to know more about it.
globalization, Dr. Zorab. Now, in no time, in 12 hours, you can go everywhere. Before it was not like that, so nobody will take care of
Yes,
these
It
yes.
diseases which
spreads
are,
faster.
yeah, these are now spread fast. Yes.
And I think now all zoonosis will be part of our curriculum. We'll pay more attention to it. As time goes by, we see all these diseases coming up. So yeah, thank you, Dr. Zainab. Dr. Saurabh, you have any last questions or comments?
I would like to thank Dr. Zainab. I know tomorrow is a working day. Dr. Zainab, Dr. Fatima, they have to go to work. I would like to thank Dr. Zainab for excellent presentation, Dr. Fatima for informative talk on DHL, Dr. Kalpana, Dr. Diari, Tawfiq for sponsoring, and all viewers from all over the world. In this busy working days, joining us, I think around 500 they joined us in this working day. So I would like to thank all of them. Our next webinar is on 15th of this month, Poisoning in Children. We will have Dr. Mahesh Moite from Bombay. And on 29th, we have in person a meeting. Dr. Joshi will be our speaker on antibiotics of choice in respiratory tract infection. And don't forget about our annual DPC, 10th annual DPC symposium on 22nd November. Thank you very much. And last word from our speakers and panelists, please.
Dr.
Yes,
Kalpana.
Dr. Zainab.
Don't panic. Well, great. Thank
Exactly.
you very much for having me. I think this was an important topic, and I'm sure there are going to be lots of other questions and follow-ups, and perhaps when there's more information, we can have another webinar with updates. But thank you all for joining on a weeknight, and thank you for having me. Appreciate it.
Thank
We
you,
need
Dr.
to thank
Zainab.
you,
Thank you.
really.
Thank you,
Thank
Dr.
you, Dr.
Saurabh.
Fatima.
Thank you for all audience. And I am really glad that our country is, mashallah, proactive. They are prepared with everything. And we look forward, inshallah, not to have any diseases related to Mpox. Thank you so much to all.
Shukran, Dr. Fatima. Shukran.
Thank you,
Shukran.
Dr. Fatima. So yeah,
Thank you
with
and
this,
good night. Thank you very much.
good night. We
Good night.
close the
Bye.
session. Thank you.